Welcome! Let's talk about the electrocardiogram. You look at that tracing and it seems like just a simple line going up and down, right? Well, in reality, it's an incredibly powerful window into the heart's electrophysiological function. To really understand what it's telling you, you can't just guess. You need a system. And that's exactly what we're going to deconstruct today, a systematic methodology that is an absolutely foundational skill for any serious clinician or researcher. So, let's get into it.
So here's how we're going to tackle this. Think of it as our roadmap. We'll start with the big picture framework. Then we'll dive deep into each piece of the waveform, rhythm and rate, what the atria are doing, what the ventricles are doing, and how they recover. Now this order is absolutely critical. It's not arbitrary. Each step builds logically on the last, so by the time we're done, we've built a complete and coherent clinical picture. We'll wrap things up by looking at the key intervals that pull it all together.
Before we get into the nitty-gritty of the system, let's just take a moment to look at what we're actually analyzing. This is the standard ECG waveform. It's essentially the language of the heart's electrical system. And it's this rich tapestry of deflections, intervals, and segments that we're going to learn how to read. Each little bump and wave carries profound diagnostic meaning. All right, Section 1. This is the cornerstone of our entire approach, the systematic framework. I want you to think of this as more than just a simple checklist. It's really a cognitive scaffold, a mental structure that forces you to be thorough and prevents you from missing crucial details. It's what keeps you from making errors. And here it is. This is the core methodology, the analytical pathway you'll follow every single time. Notice the flow. It's so logical. You start broad, with a global assessment of rhythm and rate. Then you zoom in, looking at the atrial events, then the ventricular events, and finally, you synthesize the whole cardiac cycle. Every step is a prerequisite for the next one, and together, they form a coherent diagnostic narrative. So our analysis always kicks off with the two most fundamental parameters, rhythm and rate. Why here? Because these give you the most immediate assessment of the heart's electrical stability and its overall timing. It's the first clue to whether things are stable or not. Now, assessing the rhythm isn't as simple as saying regular or irregular. It's actually a nuanced three-part process. First, you look at the QRS complexes. Are they marching along at a regular interval? Next, you have to play detective and hunt for the P waves. Is there evidence of organized atrial activity? And finally, this is the most critical part. You have to establish the relationship between the P waves and the QRS complexes. Are they talking to each other? Answering that tells you exactly where the heart's rhythm is coming from: sinus node, atria, junction, or ventricles. And it reveals the integrity of the whole conduction pathway. Okay, once you've defined the rhythm, you quantify the rate. For an adult at rest, the accepted normal sinus rate is between 50 and 100 beats per minute. This range reflects the natural firing rate of the sinoatrial node, with a little influence from the autonomic nervous system. Now, if you see a rate outside this range, bradycardia or tachycardia, that's not a diagnosis in itself. It's a sign that demands you dig deeper and figure out the underlying cause. Let's move on. We're now turning our attention to the very beginning of the cardiac cycle, the P wave and the PR interval. These two elements give us a really detailed look at the atria, specifically how they depolarize, and then how that electrical impulse travels through the atrioventricular node. Here, we've magnified that first part of the waveform. That initial positive bump, that's the P wave. It represents the sequential depolarization of the right and then the left atria. The PR interval, which we measure from the start of the P wave to the start of the QRS complex, includes that atrial depolarization, but also, and this is key, it includes that critical physiological delay happening inside the atrioventricular node. Now, it is absolutely not enough to just see that P waves are there. You have to perform a detailed morphological analysis. What's their shape? Their amplitude? Are they all uniform? For example, a tall, peaked P wave might point to right atrial enlargement. A wide, notched P wave often suggests left atrial enlargement. An inverted P wave? That could mean you have an ectopic pacemaker somewhere in the atria. Every single one of these subtle variations carries real diagnostic weight. The normal duration for a PR interval is between 120 and 200 milliseconds. And that timing isn't random at all. It reflects the slow conduction through the AV node, a crucial delay that gives the ventricles enough time to fill with blood before they contract. If a PR interval is shorter than 120 milliseconds, you might be looking at an accessory pathway, a sort of electrical shortcut. And if it's longer, that's the classic hallmark of an atrioventricular block. Our next point of focus is the most obvious, most prominent feature on the ECG, the QRS complex. This series of really rapid deflections is the electrical signature of ventricular depolarization. It's that massive, coordinated wave of electricity that triggers the powerful contraction of the heart's main pumping chambers. So here we can see the different parts of the QRS complex. That initial negative deflection, the Q wave, often represents the depolarization of the septum. The big, tall, positive spike, the R wave, reflects the depolarization of the main mass of the ventricles, and the S wave that follows is the final depolarization of the base of the ventricles. The shape and the size of these waves are just incredibly important for diagnosis. Analyzing the QRS complex is a multifaceted process, and we're guided by these 4 key parameters. First, morphology. We're looking for specific patterns, like what you'd see in a bundle branch block or with ventricular hypertrophy. Second, duration. It should normally be less than 100 milliseconds. This is a critical indicator of how fast that electrical signal is spreading through the ventricles. Third, voltage, or amplitude. This gives us clues about the mass of the ventricular muscle. And finally, the electrical axis. This tells us the net direction of ventricular depolarization and can reveal conduction defects or even changes in the heart's anatomy.
So we've analyzed depolarization, the electrical activation. Now we have to look at its counterpart, repolarization. This is the electrical recovery of the ventricles, and it's a complex process that's reflected on the ECG by the ST segment, the T wave, and sometimes a U wave. You really have to pay attention here, because these components are extremely sensitive to things like ischemia, infarction, and electrolyte imbalances.
On this waveform, we can really see that repolarization phase. The ST segment, which starts at the J point and goes to the beginning of the T wave, should normally be flat, right on the baseline. The T wave itself represents the bulk of ventricular recovery. And the U wave, if you see one, is thought to be the repolarization of the Purkinje fibers. Any deviation in these segments and waves are often the earliest and most specific signs of myocardial injury. Evaluating repolarization follows a very strict sequence. First, you analyze the ST segment. Is it elevated? Is it depressed? Any deviation from that flat baseline can signal acute myocardial injury. Then, you assess the T wave. What's its morphology? Is it upright or inverted? Is it tall and peaked, or is it flattened? These changes can point to a huge range of pathologies. And finally, you note if a U wave is present and what it looks like, because it can become prominent in conditions like hypokalemia.
Okay, we're at our last section. Here, we're going to wrap things up with a quantitative synthesis of our findings. We'll consolidate all those critical numbers that define a normal ECG and give us a framework for spotting pathology.
This is your high-yield summary, the cheat sheet of key parameters. We've got the heart rate, 50 to 100, showing normal sinus node function. The PR interval, 120 to 200 milliseconds, indicating normal AV conduction. The QRS duration, nice and tight, less than 100 milliseconds, which means rapid conduction through the ventricles. And finally, the QT interval. This represents the total duration of all ventricular electrical activity, and it's critically important. But it's also a bit tricky because it changes depending on the heart rate. So it has to be rate-corrected to be interpreted properly. Why does this matter so much? Because a prolonged corrected QT interval is a huge risk factor for life-threatening ventricular arrhythmias. And this brings us to the whole point of this rigorous methodology. We've established the parameters of what's normal. But the real art and science of electrocardiography is in understanding how just a single deviation, a subtle change in a wave shape, a tiny prolongation of an interval, can begin to unravel a complex clinical story. This framework isn't just a tool for interpretation. It is the absolute foundation upon which sound clinical judgment is built.